Welcome yet to another episode where we get to share information with you who is watching and listening. And today's episode is going to be about giving birth, delivery. Uh, we want to really break it down, what is involved in delivering, the different types of ways, different types of giving birth, and what to really look forward to. So I'm very, very honored to have Dr. Shad with me.
Thank you, Dr. Eladu.
Yes, Dr. Shad will say something about herself, but she'll be the one to lead the discussion and ask the questions.
Okay, let me start. So, Dr. Eladu, are you ready for the headache? Because I'm going to ask as many questions as I want.
Please, you're very free.
So, I want to know about, okay, there are many questions that are going on about if it's a normal vaginal delivery or a C-section. So, I would like to know, first of all, what do you expect during delivery?
All right.
And when do you go for a normal vaginal delivery versus a C-section?
So I know there could be someone out there who, yeah, they're expecting. Maybe it's their first baby and they don't know. They are anxious and they just don't know. So, whereas the journey that you've had has moved towards 9 months, usually the very important events of the pregnancy is the time of giving birth, and most times we try to prepare patients, but I've also noticed that as doctors we don't prepare patients enough. So most times we prepare you for just a normal vaginal birth. And if it doesn't happen, you don't have information about the cesarean section, you become very anxious. And at that point in time, it's very difficult to share information because if someone is in labor, they are definitely going to be very irritable. They're not willing to listen to all these things. Yeah, but briefly put, delivery is the final phase of the pregnancy. So this is the time when you actually get to bring forth this baby out of the womb into the world that you're living in. And there are two ways of giving birth. There's a normal vaginal birth, and then there's a cesarean section. Now they are all effective, right? Uh, if you look at it in terms of statistics, uh, the majority of women giving birth vaginally are more than those who are having C-sections. We look at about 68 to about 70% of women tend to have normal vaginal births compared to about 20 to about 30% of those who have a C-section. So to encourage people out there, not then, it may seem like there are more people having C-sections
C-section than normal
than
vaginal.
than vaginal birth, but that's not true. There are more people having vaginal birth globally compared to those who are actually having C-sections. Yeah, so delivery is it's just a way of bringing
So,
forth life.
let's say the mother comes to you. So, how do you end up deciding if she's going to benefit from C-section or it's going to be a normal vaginal delivery?
So deciding on the way of delivery is actually, it's an accumulation of events. For example, it starts from antenatal. When the mother comes for antenatal, we are definitely screening this mother. All right, depending on the risks that she has. If someone has had a very calm pregnancy, uneventful, no complications, all right, and then when she reaches the point when she's nearing to give birth, and most times I tell my patients above 37 weeks, you know that your baby is set, your baby is mature, and your baby can come at any one time. So above 37 weeks, you should have really had that discussion with the patient. But the antenatal helps us to identify risks that might make it difficult. Now, we prefer, if anything, I would like for all patients to have a vaginal birth. All right, and for the reasons that a vaginal birth is, it's not quick, but the recovery is very quick. All right, when you've given birth normally, and if you don't have any complications, you get to recover very quickly. You stay in hospital for a very short time, at most about 24 hours. You can have as many children as you want. Sometimes I speak to patients about the family size they have. Someone will tell you, I want 8 or 10 children. So you know that's a person who you would prefer to have
Vagina.
vaginal birth. Uh, and then also the costs. The costs are really a bit fairer for vaginal birth as compared to C-section. So for all patients, we always start from the point that if this patient can have a vaginal birth, well and good. But the antenatal is a period where we get to discover and find out if you have any risks that may stop you from having a vaginal birth. So now, when you reach 37 weeks, your doctor is going to sit down with you and really discuss about the birthing methods and all that. But then also they will get to assess you. For example, we have what we call a pelvic assessment. Most times it's done either in labor or about 38, 39 weeks there. That's when we get to check the bones. For you to be allowed to progress to give birth normally, you should not have any risks. Okay? Your baby should be in a very good condition and healthy. Your bones or your pelvis should be adequate, all right? Should be spaced enough to allow for that baby to pass. So when we assess and we think that you don't have any risks that could block you from having a vaginal birth, and then we allow you to go into labor. So most times we do this before labor. Sometimes when you come in labor, your doctor is going to check and see, can your bones allow the baby to pass? Is your pelvis adequate? Then if you don't have any risks, we allow you to try or to go through labor. Again, it's not a guarantee because even during labor, the emphasis is when you get into labor, we monitor you and your baby. Okay. For the mother, we are monitoring to see if she's progressing. Is she getting contractions? Is the cervix opening? All right. Then the baby, we monitor the heartbeat of the baby. Is it within the normal range? So if the mother is progressing well, the centimeters are opening, we want them to reach 10 centimeters. The mother has very good contractions, the baby is okay, then we shall allow that mother to progress until she reaches 10 centimeters. Then we will ask her to push, and then that mother will be successful at having a vaginal birth. So it's really, if there are no risks during the antenatal, then we'll give you an opportunity. But also during the antenatal, we can discover certain risks. For example, you may find out someone has had pelvic surgery before, they've had a fracture before, or you may discover that they have had 2 other cesarean sections before. Or you may discover that this baby is extremely big. The baby may be about 4 or even 5 kilograms, okay? And then maybe you get to examine her, to examine the pelvis, and then you realize that this pelvis is very narrow. So all these are risk factors that may not be in favor of having a vaginal birth. Okay. So then if we discover them early, we can actually talk with the patient and advise her that it's best for you to have a cesarean section because the risks that you're going to encounter are going to be more than if you had a C-section. Yeah. So antenatal helps us to really get to see the risks, and then we will allow the mother to progress in labor, and then if everything is okay, then she's able to push.
Okay. Are there times when the lady is already doing her vaginal delivery, she's pushing, but then you kind of to let her to pause to go for a C-section?
Yes.
Okay. So, like, in what condition?
So
When do you
okay.
allow for that to happen?
Don't happen. So we cannot guarantee 100% that you will push. Sometimes I get patients who tell me, Dr. Emma, doctor, please promise me I will push. I cannot guarantee that. You get it? But what I can guarantee is that we will monitor you. All right? Because a lot of things change during labor. All right?
So, what are those complications that made you
So,
change
number
your
one,
mind?
the baby. The baby is a very important factor. Remember, the emphasis is that we want you to have a healthy baby, and the mother should be healthy as well. So when we monitor the baby during labor and we notice that the baby is not fine, let's say the baby's heartbeat is rapid, okay, it's above 160 or it's below 120, and then despite the interventions, we are not improving, all right? Unlike for adults, babies don't have a very long window of adapting. You get it? So most times we'll give you about 1 or 2 hours of trying to monitor and intervene. If there is no improvement, then it may be safe for us to deliver that baby before complications occur to that baby, which can even include death of the baby. All right. So the baby is a very important determinant on if a mother is going to progress and push or not. Number two, is the mother herself progressing? Dr. Shad, labor is, people out there assume that when you get into labor, that it's just a matter of shoo, yeah,
Pushing the baby and that's it.
that you when you get the contractions, the baby just
Comes out.
flies out. But I keep telling patients that there are about 8 movements. There are about 8 ways or uh, changes the baby must undergo before the baby comes out. For example, the baby must engage in the pelvis, meaning that the baby must actually put its head down and start entering into the pelvis. That baby must descend into the pelvis. That baby must flex the head while in the pelvis, must undergo internal rotation. Then it has to extend the head. Eventually, when the head has been extended and has come out of the pelvis, then the doctor or the midwife is able to receive the baby. So people just assume that, oh, you're getting contractions, the baby
Magic.
should just fly out. There are movements that the baby must make that are not under the control of the doctor, nor are they under your control. So if you are progressing in labor, labor does not lie. And I keep telling patients, if everything is okay, we will see you progressing until you reach 10 centimeters. But if there is any challenge in the labor, we will see you delay. That is when your doctor or midwife is going to come and examine you and find that you're still 2 centimeters. After another 4 hours, you're still 2 centimeters. After another 4 hours, you have just moved 1 centimeter. As long as you start progressing poorly or slowly, there is a problem. Okay? And unfortunately, everyone has got a limit. Okay? The mother will reach a point and she'll get exhausted. She's having all the strong contractions, but she's not progressing. You get it? And then you, as a doctor, you know truly well that there is a problem. Or you even notice the baby is also beginning now to show signs that they're not actually fine. So we monitor the mother and monitor the baby. If both the mother and the baby are doing well, that is a person we will give as much time as possible to actually progress and then give birth. Normally, we joke in the medical spaces that the mother, the two sunrises or two sunsets should not happen without the mother delivering. I mean, by the time you're taking more than 2 days, the sun has risen and has set for 2 days, and you've not given birth, you're in labor, that might be a bit longer for you, and you may end up having complications. But we are not really driven by time. We're driven by you being fine and the baby being fine. As long as those two are okay, we'll give you as much time until you eventually push your baby. But if at all any of those things changes, you're not progressing well, you have good contractions, or you've started convulsing, okay, I cannot insist and say you must push when you're not actually conscious, you get it, or you're not stable. Or if your baby is not okay, we will not insist on that. We want you to actually go home with a healthy baby. So those are some of the things that actually change during the time.
Because I'm sure there's a misunderstanding of doctors just want money, and I'm sure people can be saying that. Can you imagine? I wasn't doing vaginal delivery. I almost delivered my baby. Then the doctor just took me to do a C-section.
Yes, there's that misconception out there that hospitals do C-sections because they
I
want
want
money.
money.
Yeah, and they will say doctors do C-sections because they want money. But you see, that is not true. Now, are there people who actually do that? Yes, they could be there. But me, that's why I really emphasize, and I want to encourage patients out there, please try to learn as much as possible during your pregnancy and during the preparation. Because if you're not informed, then it's easy for you to be gullible. It's easy for people to play around with you. But if you're informed and then you ask for explanations, when you're in hospital, you still have the right to understand what is happening. Ask the questions. Your doctor owes you the responsibility of an explanation. If things are not going well, your doctor should be able to explain to you that, look, ABCD is being done, but we're not progressing well. You get it? It is unfair for a patient to go in for a C-section when they don't know why. You get it? And most times I've had patients beg for C-sections in labor, and we don't give them C-sections. If anything, and the midwives can bear me witness, and other doctors, that majority of patients, especially those not having an epidural, are going to ask for C-sections. You get
So
it?
epidural, when do you consider giving the epidural?
All right. So an epidural simply is an intervention involving taking away
The pain.
labor pains. All right. So, one, we prefer to give an epidural when the mother has progressed a little bit. Most likely, she's about 3 or 4 centimeters. That is when we can give that mother an epidural. But also it depends on the discussions you've had with your anesthesiologist, the person who gives an epidural. Some people want an epidural even at 2 centimeters or even before the labor starts. Okay, so those are the people that will get an epidural even before the labor process starts. Okay, but it's very important that you have a session before you come into labor with the anesthesiologist who's going to attend to you. Okay, because it requires a lot of planning for you, for the person to be there for you. You get it, to keep on monitoring and ensuring that your pain is actually under check and you're not having pain that's really unbearable. So yeah, the epidural helps you not to perceive pain. Okay, we will have a session where I'll talk maybe with the anesthesiologist about epidural. But simply put, an epidural is an injection that is given on the back, and it takes away the perception of pain from the mother. Now, it does not stop labor. You are going to continue having the contractions happening, but you will not sense or
Much
you'll not
pain.
perceive the contractions, or you'll not perceive the pain that comes with the contractions.
Okay. And then, okay, when it comes to first time mothers, and then let's say a mother of four, five, which one will you go for? Let's say she had a C section before, she's not a first time mother, she did two C sections before. So now, when she comes to you as an antenatal, where will you advise her to be?
Yeah, so again, when you come to the point of discussion about giving birth, if you have one previous C-section, and especially if it was because of a non-recurring cause, then you stand a chance of trial of vaginal delivery after cesarean section, what we call a VBAC. So one, you should just have one C-section. Number two, you should have at least spent 18 months, 18 to about 24 months before conceiving. All right. So most times we tell the mothers take at least 1.5 years to about 2 years after your cesarean section to conceive. Don't come within the 2 years when you're pregnant already. All right. But take at least about 1.5 months, well, 1.5 years to conceive. Then you will stand a chance to be given a trial. We try vaginal birth after cesarean section. All right. So if you come and you've had two previous scars, your risks are going to be higher. All right. And the risks include things like rupture of the uterus, risks include things like placenta previa. Okay. And those are things that we don't take for granted. You may even we would normally encourage any mother who has had two previous C-sections and above to actually plan for another C-section.
Okay.
Yeah.
All right. So, okay, some people fear vaginal delivery because of the complications. Like they'll tell you have a bad tear, then
Yes.
it will come with complications. So, how would you address that? Will
So,
she fully recover after? Like, how would the process be?
so vaginal delivery has its benefits. I've already mentioned them, but it also comes with certain risks
Complications.
and complications. For example, tearing. Tearing is only known in vaginal delivery. Mothers who have C-sections will not have vaginal tears. You get it? It's only mothers who have had normal vaginal birth who are at risk of getting tears. All right, and the tears vary. Okay, you can have what a small tear known as a first degree tear. You may have a second degree, or you can even have the worst, the extreme of cases, the third and fourth degree tears. Those are the ones that involve the sphincter of the anal area. So you may find such a patient after they have given birth normally, they will fail to control stool, they can't control the gas or the flatus. Okay. Some of them may even end up with fistulas, all right, where there's a stool coming out of the vagina. That's a rectovaginal fistula. And sometimes, if the labor has been prolonged, they may even end up with the vesicovaginal fistula, where urine is just leaking on its own. So those are some of the complications that occur during vaginal birth. But also we've seen things like bleeding, all right, postpartum hemorrhage can occur during, or even a cervical tear can occur during what? During vaginal delivery. But those complications versus the benefits really, really far outweigh the complications. Yeah. So again, if someone has an opportunity to have a normal vaginal birth, would encourage them to have a vaginal birth, despite the possibility of the complications that occur with them. But also, we try to train and teach these mothers on what to do to make sure that they don't end up with the tears. For example, doing a perineal massage during the 34, 35 weeks until the time of giving birth. It helps stretch the muscles of the vagina, relax them, and eventually minimizes on the tearing that occurs during
Okay,
labor.
let's say that she got a third degree or fourth degree. Is it like, can you manage to help her and like repair the tear and she'll be back to normal, or she's going to continue with the fistula?
Yeah, so even with fistulas are repaired, okay? Yeah, fistulas are repaired. But during the time of giving birth, it's very important to have someone who is well trained at that point, because the first thing is trying to identify the type of tear. Okay, if the person who is helping you give birth does not identify the severity of the tear, then even the repair is not going to be adequate. Okay, yeah, but yes, we can actually repair those tears at the point of birth, especially third and fourth degree tears are best repaired in theater, all right, because we want the mother to relax, to be calm, so we are able to really do a good job trying to bring back those muscles together, stitch up, and then allow for proper healing. But also for examination purposes, when you get this tear and you remember at that time, if you're not under an epidural, find that you're very restless, you are anxious, so the doctors or the midwives may not be able to examine you properly. Okay, and then that can actually lead to omission and maybe not repairing you well. But for the first and second degree tears, those ones can be repaired even in the labor ward, and the mother should be able to recover well and actually go on to live a normal life.
Okay, so she's going to continue having her normal life.
She should be able to have a normal life. But of course, I know tearing sometimes. I've had patients who tell me, doctor, the reason why I don't want to have a
Yes,
normal.
because most of them they are scared from vaginal delivery because of that.
Yeah, so patients out there think that if you have a normal vaginal birth, that you're going to be stretched
Yeah.
completely, that you will not have, you'll not enjoy intercourse with your partner and all that. But I think that only happens if, for example, you have a tear that is not repaired. Okay, if you have a second degree tear and it's not repaired well, you will find that you will feel a bit lax. The muscles will be laxed, and then you may not be able to really enjoy the intercourse and all that. But also sometimes some repairs can be so overzealous that we end up over tightening the muscles, and then you still end up feeling a bit of pain during intercourse. So it's important that the repair is done well. If it's done well, then you should be able to lead a normal life.
Okay. And then if we can come back to C-section,
Yeah.
okay? So if it's okay, apart from the complications you said and all that, let's say it's a first-time mother. Which first-time mothers will you actually let them go for C-section straight away without trying labor and all that?
So, a first time mother that we would recommend C section is one, a first time mother who has a very narrow pelvis. All right. So, even when we're looking at, for example, the reasons for C section, there are what we call maternal reasons and
Fetal.
fetal reasons, or the reasons because of the mother or the baby. All right. From the mother's side, we assess things like the bones. Okay, the pelvis. Is the pelvis spaced enough? In the medical word, term we use is adequate pelvis. Okay, so if the pelvis is adequate, then most times we will advise this mother that, look, even if you labor for 1 week, it's going to be unlikely for you to push this baby. So the narrow pelvis. Number two, if the baby is extremely big, okay, most times we assess and see how the pelvis is compared to the size of the baby. If the baby is more than about usually 4 or 4.5 or even 5 kilograms, we assess comparing it to the pelvis. The bigger the baby, the more difficult it will be for the mother to push, and also more complications. Big babies are likely to overstretch the perineum, and it may even cause you to have a fourth degree tear or a third degree tear. Now, that is not worth it, really. Going through that tear, sometimes the healing and the recovery is longer than actually having a C-section. So most times we would recommend such mothers to have cesarean sections. Mothers who have had fractures, okay, on the pelvis and all that. Those are mothers you may not really want to encourage them to have a C-section. The mothers who may be having other underlying conditions, those ones who could be having cardiac conditions, okay, holes in the heart and all that, that you think the labor mate really will stress or worsen their well-being or their underlying disease, you may actually recommend them to have a C-section. Okay. Now, things like pressure and diabetes are not a direct reason for C-section. There should be another risk. Okay, besides just pressure, because if a mother has what we call hypertension or preeclampsia in pregnancy and it's controlled, we can induce that mother and she's able to push. The same with the diabetes or gestational diabetes. So those are not really direct reasons, but also the doctors who are managing you are able to assess and see, are there other risks besides just this. Now, that's on the mother's side. On the baby's side is mostly, is the baby tired or not? All right, if the baby is tired, uh, then that would be a reason for a C-section, because you don't want the baby to come out when the baby can't breathe and all that. Sometimes also we have done C-section, especially if the placenta is on the lower part of the uterus, because if the placenta is down, it can end up blocking the path of the baby and it can cause extreme bleeding, what we call antepartum hemorrhage, and then that could actually result into a C-section. We have also seen mothers where the placenta detaches before its time. Okay, maybe if a mother fell down or she had an accident or something, she slid at home or something, and then the placenta separates before its time, that is a life-threatening condition that requires you to intervene quickly to actually deliver such a baby. We've also seen scenarios where the babies could be having anomalies. All right, baby could be having a very big head, hydrocephalus. That's a baby you may not be able to deliver such a baby, or a breech baby. A breech means the baby is facing up, the head is up and the feet are down. And for a first-time mother, but the recommendation would be for you to have a C-section, because a breech delivery, especially if it's not conducted by someone who is skilled, can easily result into injuries to the baby, or the baby getting tired and all that, and then the outcomes are not very good. So for first-time mothers who have breech presentations, we are likely to encourage them to have a
C-section.
C-section. Yeah, but again, uh, the reasons are not just limited to what I've discussed. There are other, depending on really the discussions you've had with your doctor. If your doctors feel that there is a reason, or your baby is at risk, or your life is at risk, then they will most likely want to expedite the process so that both you and your baby are healthy.
Okay. What's your advice to the mothers that would be like, no, even if it's a first time, no complications, antenatal went well,
Yeah.
but they'll be like, no, I just want a C-section because I don't want to go through the vaginal birth pain.
So that is termed as cesarean section because of maternal request. Now, again, times have changed. These days, Dr. Shad, we get mothers who come and ask you and tell you, doctor, for me, I don't care what you will tell me, but I am not going to push. I want a C-section. Now, truthfully, we don't encourage C-sections because of maternal request. And the first steps that we do is we try to counsel the patient or the mother and even the couple. We will tell them the risks that come with C-sections. Okay, I haven't mentioned them, but C-section has a lot of risks.
Okay,
Okay,
can you tell us some of them?
yeah. For example, the recovery time is really slow. Someone who has had a vaginal birth versus someone who has had a C-section, vaginal birth recovers very quickly, especially with no complications. You will stay in hospital for a longer time for C-section. Most times, in most places, they keep you for about 24. I mean, they keep you for about 48 to about 72 hours in hospital, right? Bleeding. You are at risk of greater amounts of blood loss in C-section compared to vaginal delivery, because it involves cutting the muscles or cutting the skin and separating the muscles, cutting the uterus. So that is all Those are all avenues that may increase the tendency to bleed. All right, but also infections. All right, because there's a separation of these layers and all that, bacteria can easily get into and cause you infection. All right, of course we prevent that by giving you antibiotics, but we do not know infections can set in at different times, maybe even after surgery, and you don't take good care of the cord, I mean of the incision area, you may predispose yourself to getting infections that can result into pus and all that, but also injuries to other organs. We've seen people get bladder injuries during C-section. We've seen people get gut injuries during C-section. All right. Yeah, although those are not very common, but they can actually occur. We've had women who have complained of back pains for a long time because of the spine, especially if they have had multiple pricks on the back. All right. And then also, C-section limits the number of children you'd be recommended to have. If Dr. Shad, you want to have 8 children, and you've had C-sections, we are likely to really, really restrain you and advise you to have maybe four at most, maybe 6. You get it. But already, each subsequent C-section puts more danger to your life, right? So then, at some point, we'll have to advise you to actually opt for tubal ligation so that you don't actually come back when you're pregnant
So if I
again.
want a football team, you let me have vaginal delivery better
So
than
if you want a football
everything where
team, Dr. Shad, pushing should be your prayer. That whatever happens, you should be able to successfully push, get it. Because once you start having C-sections, then your numbers also get
the
yeah,
decrease.
get,
Okay, you
get
talked
reduced.
about the risks of C-section.
Yeah.
So, okay, what are the benefits of also having a C-section?
Yeah, so again, the benefits are that C-section, unlike for labor, because you see labor takes time. First time mothers can even take about 24 hours in labor. For C-section, when you have a C-section, it cuts that time within you don't have to you don't have to endure all those hours. You get it. And on average, a C-section takes about 1 to 2 hours. You get it. And then you are out of that suffering and the labor and all that. So we've seen in terms of both maternal and baby outcomes, C-section is more helpful. Instead of you, if a mother goes through labor and then the baby gets tired and the baby can't breathe and then we have to do vacuum extraction and all that, for C-section, you've cut all that time, and so you find that the babies most times are likely, if it's done on time, babies have lesser complications compared to maybe normal vaginal birth, and then also the mother doesn't have to labor so much and for a long time. Yeah. Basically, the benefits of C-section are to give you a healthy baby and a healthy mother.
So, okay, in conclusion, you mean that there is nothing that's superior, not C-section, not vaginal delivery. It's benefits that
Yes.
outweigh the risks.
Thank you. I think you've really put it so well that there is no birthing method that is better than the other.
Other.
All right. Now, again, I tell patients there are no gold medals or certificates given because you've pushed. No. The reward of your pregnancy should be a healthy baby and a healthy mother.
Mother.
That should be more important than even how you give birth. Sometimes I get patients who get so carried away that they are more invested in pushing than the outcome of the
The baby.
pregnancy. And it's painful because those are patients who are going to refuse to consent even when their babies are in danger. They will tell you, in my family, my mother pushed 8 children, I will not be the first embarrassment. And then they forget that it's not how you give birth, it's what are you
What's the
giving.
outcome?
Yeah, what's the outcome of that entire journey? Are you going home with a baby who is going to become an independent adult and live a healthy life, or you're going to have a baby and baby is going to need special needs and you're going to be in and out of hospital, and that baby is going to be dependent on you for the rest of their lives. So sometimes I want mothers and fathers, mostly the fathers, I want the mothers and the fathers to put in the perspective that you need a healthy baby and you need a healthy mother out of the pregnancy, not just pushing or having a vaginal birth, or versus a C-section. So there is none that is superior. Me, if you go home with a healthy baby, I'm at peace with that. You get it. But also, we try as much as possible to encourage mothers to push, because majority of them should be able to push. So when you tell me, like you told me before, a mother comes and says, I want a cesarean section,
C-section.
we first counsel you and tell you the dangers of C-section, and really try to advise you not to go for C-section. But then if you insist that for you, regardless of this
You
information,
want
you
C-section.
want a C-section, then we will ask you to consent that you've understood everything that the doctors have explained to you, but you still want to go ahead with the C-section. Once you have done that, then we will go ahead and do a C-section because you have requested for
Question.
one. So it's not like we are just ready and waiting for you to say, "Oh, I want a C-section,"
Because you want money.
because we want money. That is not true. And people out there, please make sure that you are able to have really proper discussions, ask the right questions, and really, because for you to have a C-section, there should be a good reason for a C-section. Not just because you've taken long. There should be a reason, and that reason should either involve a risk to your baby or a danger to your life, and that means we need to avoid that risk from happening.
Okay. I don't think I have another question. I didn't ask a lot, so you don't have a headache. So yeah, thank you, Dr. Eladu.
It has been a privilege, and we hope that the mothers out there and the people walking this journey of pregnancy have picked one or two things, that in terms of delivery, you could end up with a normal delivery or a C-section, depending on how your labor has progressed, and also depending on what has been done and what has been discovered during the antenatal journey. None of these are superior to the other. What we are interested in is you going home with a healthy
Baby
baby
and a
and
healthy
a
mother.
healthy mother. And once that is achieved, then we are grateful, and we hope that you can share this information with your friends. So, yeah, I think that brings us to the end.
Yeah, thank you.
Thank you so much, Dr. Shad. If you've watched this to the very end, please share it with someone who is expecting. Could be your friend, your sister, maybe your mother, or your neighbor. Please do share this information, and don't forget to subscribe to our YouTube channel. And yeah, comment if you have any comments. We'll be happy to respond. Thank you so much.